Bismillahirrahmanirrahim. Quote of the day is: the fact that an opinion has been widely held is no evidence whatever that it is not utterly absurd. Today, the topic of my presentation is evidence-based medical practice under the supervision of Professor Dr. Sarah Afzal. Learning outlines: introduction of evidence-based medical practice and steps of evidence-based medical practice. Learning outcomes. At the end of presentation, participants will be able to describe about the importance of evidence-based medicine and steps that are involving in this procedure. Introduction. Evidence-based medicine is the conscious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The aim of evidence-based medicine is to integrate the experience of the clinician, the values of the patient, and the best available scientific information to guide decision. History. Dr. Benjamin Spock from 1903 to 1998, American child care specialist and author of the best-selling book Baby and the Child Care, recommended that infants sleep in the prone position. Dr. Spock was considered an expert in child care and his reasoning seemed quite logical. Infants sleeping on their back may be more likely to choke on vomit. Without question, millions of healthcare workers and families began to follow Dr. Spock's advice. Unfortunately, no conclusive evidence existed that sleeping on the stomach was safer for infants than sleeping on the back, and as a result of untested practice, thousands of children died as a result of sudden infant death syndrome. Examples of untested treatments are also found in surgical literature. In this particular example, a commonly used invasive treatment was later found to provide no better outcome than less invasive treatments. For example, radical mastectomy. It developed in early 19th century by William Halsted from in 1852 to 1922 was the most common method for testing breast cancer. At the time, cancer specialists believed that breast cancer grew slowly from the tumor outwards towards the lymph nodes and that extensive removal of the affected area should cure the cancer. Based on this belief that more is better, the radical mastectomy involved the removal of affected breast, pectoralis muscle, and in most severe cases, removal of the ribs to assess the lymph nodes. Unfortunately, after widespread use of this extremely invasive procedure, survival rates did not improve. This caused cancer specialists to revise the original theory, prompting the use of lumpectomy, a less invasive surgical procedure. These procedures are then followed by systematic reviews such as systematic treatments such as radiation and chemotherapy. Two American surgeons, George Creel and Bernard Fisher, were credited with bringing this issue to the forefront. Creel was promoting less radical procedure approach. Fisher and his colleagues began conducting randomized controlled trial to compare the effectiveness of radical mastectomy and lumpectomy followed by irradiation for breast cancer treatment. After 20 years fellowship, their results suggested that lumpectomy, followed by radiation for breast cancer treatment, was equally effective as radical mastectomy at treating breast cancer. If not for this newfound evidence, more women would have undergone the unnecessary and highly mutilating procedure without added benefit. Many additional trials were conducted in the United Kingdom, Italy, and Sweden for paving the way for the very first systematic review on cancer treatment. All this brings us to a new paradigm for medical practice, evidence-based medical practice. For example, thalidomide for pregnant women and internal memory artery ligation for reducing ischemic heart disease are notorious examples, but plenty of others abound. By providing the data that are difficult to initiate, evidence-based medicine has helped to stem theoretically logical but potentially harmful decisions. Importance of evidence-based medicine. Important points are: it de-emphasizes a hunch or gut feeling. unsystematic clinical experience, and it anecdotal evidence as sufficient grounds for clinical decision making, and stresses the examination of evidence from clinical research. There are 5 A's for evidence-based medicine: ask, acquire, appraise, apply, assess. Steps in evidence-based medicine. The full-blown practice to evidence-based medicine comprises following 5 steps: converting the need for information about prevention, diagnosis, prognosis, therapy, causation, etc., into an answerable question; tracking down the best evidence with which to answer that question; critically appraising the evidence; integrating the critical appraisal with our clinical expertise and with our patient's unique biology, values, and circumstances; evaluating our effectiveness and efficiency in executing and efficacy, and seeking ways to improve them. 5 steps of evidence-based medicine are shown the diagram. Step 1 is ask a clinical question. Step 2 is to acquire the best evidence. Step 3 is appraise. Step 4 apply, and step 5 assess. Step 1, converting the need for information about prevention, diagnosis, prognosis, therapy, causation, etc., into an answerable question. For formulating an answerable question, PQ is what we need to remember. In PQ, P stands for patient or population. We should define what are the most important characteristics of the patient whom we are talking. I stands for intervention. What main intervention are we considering, and what do we want to do with this patient? C stands for comparison. What is the main alternative being considered if there is any other comparison? O stands for outcome. What are we trying to accomplish, measure, improve, or affect? Why PICO? To get the question clear in your mind, to identify the information you need to answer the question, to translate the question into searchable terms, to develop and refine your search approach. It looks easy, it can be tricky, it is absolutely invaluable. A minute spent properly formulating your question will save your hours in searching. Clinical scenario. A 25 years old male presents to the emergency department with a traumatic laceration to his left index finger. The wound needed a thorough clean and will require suturing, and you decide to do this digital nerve block technique. A colleague who has recently worked in a plastic surgery department suggests that you should use epinephrine with a dilution of 1 into 100,000 to develop with to help with the homeostasis. But you have already been told that it can cause finger necrosis and that it should never be done. You wonder whether in fact this is true and decide to look at the evidence for yourself. Questions can be: can a patient with no underlying vascular compromise undergo digital block? Can analgesia be obtained without causing ischemic complications? Is local anesthetic agent with low dose epinephrine as safe as local anesthetic alone? After we have converted the clinical problem into an answerable question, we generate appropriate keywords. Keywords in this scenario can be anesthesia, nerve block, digits, or epinephrine. Search strategy. Traditional sources of information are asking colleagues, experts, reading textbooks, journals. Secondary sources of reliable summarized evidence include Archimedes, clinical evidence, best bets, but the quality of information obtained from this source is variable. Other important sources of evidence includes bibliographic database, which allows thousands of articles to be searched in a relatively short time period. The ability to search following database effectively is an important aspect of evidence-based medicine. Cochrane Library Database, Medline, Embase, Senahill, and Archimed. These are the different relevant papers as a result of search outcomes. Clinical bottom line. In the absence of underlying vascular compromise, epinephrine with a dilution of 1 into 200,000 to 1 into 100,000 is safe to use in digital blocks along with local anesthetics. Step 2. Tracking down the best evidence with which to answer that question. What qualifies as best evidence differs by clinical question and rating scales. For example, randomized controlled trials are most appropriate for therapy outcome, but not appropriate when looking at prognosis of a disease. Highest evidence would come from cohort study or systematic review of cohort study. A number of groups and organizations have attempted to classify high quality versus low quality evidence. Evidence rating scale for therapeutic studies. Levels of qualifying studies. Level 1, high quality multi-centered or single-centered cohort study validating a diagnostic test with standard as reference in a series of consecutive patients or a systematic review of these studies. Level 2, exploratory cohort study developing diagnostic criteria with standard as reference in a series of consecutive patients or a systematic review of these studies. Level 3 is diagnostic study in a non-consecutive patients without consistently applied standard as reference or systematic review of all these studies. Case control study is level 4 is a case control study or any of the above diagnostic studies in the absence of a universally accepted standard. Level 5 is expert opinion, case report or clinical example or evidence based on physiology, bench research of first principle. Evidence rating for diagnostic studies. High quality level 1 is high quality multi-centered or single-centered randomized controlled trial with adequate power systematic review of these studies. Level 2, lesser quality randomized controlled trial prospective cohort study or systematic review of these studies. Retrospective comparative study is the level third. Case series is level 4. Expert opinion, reports or clinical example or evidence based on physiology, bench research of the of first principle are under level 5. Levels of qualifying studies evidence. There are also 5 levels for these. Again, the level 1 is high quality, multi-centered or single-centered randomized controlled trial with adequate power or systematic review of these studies. Lesser quality randomized controlled trial, prospective cohort study or systematic review of these studies. Retrospective comparative study, case control study or systematic review of these studies. Case series and expert opinion. In expert opinion, case report or clinical example or evidence based on physiology, bench research of first principle. Scales for grading recommendations. Grade A. Grade A is a strong recommendation. Qualifying evidence, level 1 evidence or consistent findings from multiple studies of level 2, 3, and 4. Implications for practice. Clinicians should follow a strong recommendation unless a clear and compelling rationale for an alternative approach is present. Grade B. Grade B is recommendation. Qualifying evidence level 2, 3, 4 evidence and findings are generally consistent. Generally, clinicians should follow a recommendation, but should remain alert to new information and sensitive to patients' preference. Grade C. It is described as option. Qualifying evidences for grade C are evidence from level 2, 3, or evidence or findings, and findings are generally consistent of these levels. Clinicians should be flexible in their decision making regarding appropriate practice, although they may set bound on alternative. Patients' preferences should be having a substantial influencing role. Grade D, describer is option. Qualifying evidence level 4, little or no systematic empirical evidence. Implication for practice. Clinicians should consider all options in their decision making and be alert to new published evidence that clarifies the balance of benefit versus harm. Patient preference should have a substantial role. Critically appraising the evidence. Evidence should be critically appraised for validity, impact, applicability. Many journals assign a level to the articles they publish, and authors often assign a level when submitting an abstract to conference proceedings. This allows the reader to know the level of evidence of research. But the designated level of evidence does not always guarantee the quality of research. One of the key messages of evidence-based medicine is don't believe everything you read. For example, in 2006, the journal Science was forced to retract two of its published articles after the research was found to be fabricated. This means that you need to evaluate or critically appraise the quality of evidence you have found. How do you critically appraise a published article? There are a few questions that you need to ask. First is who has written? Are they recognized authors? Are they affiliated to a recognized institution? And what are the aims and objectives? How has the right research methodology has been used? When is it recent or seminal research? Valid. Are the results valid statistically and clinically? Where has it been published in a recognized journal? Is it a paper review journal? Statistical significance. Play of chance, p-value, conventionally taken as 0.05, power of the study, conventionally taken as 80% sample size. Clinical significance, approximately 95% confidence interval. Mean plus standard deviation, odds ratio, confidence interval should not include 1. Mm, confidence interval should be narrow. Obvious bias or conflict of interest are found or not, and what are the conclusions? Step 4 in evidence-based medicine is integrating the critical appraisal with our clinical expertise and with our patient's unique biology, values, and circumstances. Evidence alone cannot answer clinical questions about individual patients, clinical expertise, and patient values and preferences are the key elements of evidence-based medicine and are equally important in clinical decision making. Only well-developed guidelines can be helpful for developing individualized treatment plan. Evaluating our effectiveness and efficiency in executing steps 1 to 4 and seeking ways to improve them both for next time. This step is the last step in the evidence-based medicine practice. Conclusion. There is no way to know when our observation about complex events is in the nature are complete. Our knowledge is finite, but our ignorance is infinite. In medicine, we can never be certain about the consequences of our interventions. We can only narrow the area of uncertainty. This slide shows evidence-based pyramid. On the top is randomized controlled double-blind studies. Randomized controlled studies are after that. Cohort studies are typically prospective observational studies, non-randomized. Case control studies, patients who already have specific conditions are compared with those who don't. In case series, case reports, ideas, opinions, all are included. Now comes the multiple choice questions. Which of the following database is a collection of systematic reviews? Sinahil, PubMed, Cochrane, and Spordiscus.
D.
A.
A is the right answer. What is the highest level of evidence, level 1, that can be used in making clinical decision? Option A, case series. Option B, randomized controlled trials with high power. Option B, randomized controlled trials with low power. And option D is non-randomized concurrent cohort comparison between contemporaneous patients.
B.
B.
Yes, B is the right answer. A certified nurse, midwife, or CNM referring a high-risk patient to an obstetrician or gynecologist is an example of which component of evidence-based medicine? Patient value, research, education, expertise.
Expertise. Expertise.
Expertise.
B is the right answer, research. What are the three components of evidence-based medicine? Expertise, research, and patient values. education, evidence, and cultural competence, patient satisfaction, insurance, and reimbursement,
Alpha.
science.
A.
A,
Uh, yes, A is the right answer. Expertise, research, and patient values are the main components. You want to assess the efficacy of a new anti-epileptic drug versus an old drug. What is the best design you choose for this purpose?
A,
A, yes, randomized control trial is the right answer. Other options, cross-sectional, case control, and cohort are wrong. A practitioner is planning for some research on causes of pancreatic tumor in males in age group 35 to 45 years. For this purpose, he gathers information from general surgeons and few patients. The source of information he is using is secondary source, traditional source, clinical evidence, or Archimedes source.
A,
Secondary source.
B, traditional source is the right answer. Secondary sources are books, journals, etc. While rating evidence for therapeutic studies, the highest level includes exploratory
Exploratory. Alpha.
expert opinion, single-centered cohort study, or case control study.
Alpha.
C is the right answer, single-centered study. Generally, clinicians should follow a recommendation but should remain alert to new information. This category is under which grade? Strong recommendation, optional recommendation, or empirical evidence?
Empirical evidence.
B,
B, recommendation is the right answer. Uh, Reference is the research methodology and thank you.
thank you very much, Dr. Isma. This is a very good presentation, and I think there are more exercises that are required in order to know what is the level of evidence and how we qualify different studies on the level of evidence. In this presentation, I would like you to please add about the certain studies and ask about their level of evidence. For example, if I ask you that if there is any evidence about a drug that is being used for a new disease, for example, coronavirus disease, how would you classify that evidence? Dr. Isma, please. Dr. Isma?